Hey, y'all get down from there before you fall. Hurry up, get down. Didn't I tell you to stop? Get off that swing like that. You know what? That's it. I'm tired of talking to y'all. It's time to go. We out of here. Come on. Come on. No, don't ask me for ice cream. Save the baby. Pediatrics. Let's talk about them children. Pediatrics and anatomical and physiological differences of pediatrics and adults. As mentioned earlier, most emergencies involving children are managed similarly to those involving adults experiencing the same type of emergency. However, there are certain modifications you may need to make based on the anatomical and physiological development of children. For the average, normally developing child, the following considerations are appropriate. For an infant or a child with special healthcare needs, the anatomical and physiological differences may be quite different from the norm, and using the caretaker to help with this assessment is critical. When you are treating a child, be aware of some of the following special conditions and situations. Also be aware that most significant of these differences typically concern the airway. Got that? There are various charts that identify ranges of normal vital signs for pediatric patients. A rough estimate of a normal heart rate, respiratory rate, and systolic blood pressure is listed in Table 38, blah, blah, blah. Pediatric blood pressures will be discussed in greater blah, blah, blah. All right. Let's talk about the airway of the pediatric patient. Infants have proportionally larger tongues than adults. All right. That's in italics. So infants have proportionally larger tongues than adults as compared to the size of the mouth, right? You got that part? Right on. You need to carefully assess the airway in a child with an altered mental status because it is easy for his airway to become occluded by his tongue. Also, the larger tongue leaves little room for airway swelling. Next, the diameter of a newborn's trachea is only about 4 to 5 millimeters, or about 1/3 the diameter of a dime. That's pretty damn small. Or the size of a straw. That gives you a much better idea. Compared to 20 millimeters for the adult trachea. All right? Huge difference. You heard that? The diameter of a newborn's trachea is only about 4 to 5 millimeters, or about 1/3 the diameter of a straw, of a dime, or the size of a straw is what it is. It's the size of a straw. Compared to 20 millimeters for the adult trachea. Injury and inflammation to the trachea caused by inhaling steam or toxic fumes, for example, can cause life-threatening airway swelling not only faster but with less exposure to the fumes, gas, steam than in an adult. All right. Thirdly, the pediatric trachea is much more pliable than the adult trachea. All right. We're still talking about the trachea here. Because children's tracheal rings are underdeveloped, with the exception of the first tracheal ring, the increased pliability of the trachea may lead to complete or partial occlusion of the airway when the neck is hyperextended or hyperflexed, or when infants are working hard to breathe. Fourthly, pressure on the soft tissue under the chin can easily cause the tongue to be displaced back into the pharynx, leading to an airway obstruction. Pressure on the soft tissue may occur during the chin lift or jaw thrust maneuver when opening or maintaining an airway. I read that kind of off tone. Pressure on the soft tissue may occur during the chin lift or jaw thrust maneuver when opening or maintaining an airway. That's why you pad behind their neck, I'm assuming. Newborns and infants are obligate nose breathers. That is, they prefer to breathe through their nose and not through their mouth. Wait a minute. I'm trying to turn the page. My hand's dried in a motherfucker. All right. Obligate nose breathers. They choose to breathe through their nose and not through their mouth. They do not automatically open their mouth when secretions, blood, or other substances obstruct their nose. If the nares are obstructed or inflamed because of infection, The newborn or infant can easily develop respiratory distress. The smallest area of the upper airway is at the level of the cricoid cartilage and not at the level of the vocal cords as seen in the adult. This is true until about 6 years of age. Let's go. Wait, this is the fifth one. My fault. I skipped right through that. I read them like they was together. They are not. Fifthly, the smallest area of the upper airway is at the level of the cricoid cartilage and not at the level of the vocal cords as seen in the adult. This is true until about 6 years of age. Sixthly, the epiglottis is much higher in the airway than in an adult. This may lead to a higher incidence of aspiration, especially when the neck is hyperextended. Let's talk about the differences in the head of a pediatric patient and an adult. Children's heads are proportionally larger than adults. You get that? Proportionally. Not that they are bigger, even though some children have big-ass heads, but proportionally their head is bigger than the rest of their body. This predisposes them to head injuries when involved in falls because the head, it's heavy as hell. Auto accidents and other types of trauma. The large occiput, back is what they're saying. The large back of the child's head causes the neck to flex forward if the child is supine on a flat surface. To prevent this during immobilization, the EMT should place a small amount of padding under the shoulders to maintain neutral alignment of the airway and cervical spine. So that's what the padding was for, not for the, same thing. Fuck it. Until a child's body proportionately catches up with the head at approximately 8 or 9 years of age, padding is necessary. Adult dimensions are reached at about age 10. Infants younger than, this is number 2, secondly, infants younger than 6 to 7 months old typically cannot fully support their own heads. Typically. I've seen some that can. I don't know what the fuck they're talking about. But, oh well, remember this shit for book testing purposes only. Always support a baby's head when you pick him or her up. Infants have a soft spot on the head from incomplete closure of the skeletal plates that make up the skull. Typically, the anterior soft spot, anterior fontanelle, the soft spot is called a fontanelle, closes between 12 and 18 months of age. The posterior soft spot, posterior fontanelle, closes by 2 months of age. Be careful when handling an infant not to press on or poke into the fontanelle, all right? So, about those fontanelle. The anterior fontanelle closes between 12 and 18 months, or 1 to 1.5 months. The posterior soft spot, the posterior fontanelle, closes by 2 months. So the posterior fontanelle closes first. Anterior fontanelle closes later, 12 to 18 months. Got that? Good. Assessment of the fontanelle. To determine if the fontanelle is sunken, indicating dehydration. Sunken fontanelle indicates dehydration. Or if the fontanelle is bulging, indicating increased pressure within the skull. So if the fontanelle is bulging, the child has pressure in the skull. Is not very acute. I'm making up shit. Okay. If the fontanelle is bulging, indicating increased pressure within the skull, is not very accurate and may be difficult to perform in the pre-hospital setting. To identify a possible increase in intracranial pressure, it is much more important to recognize a decreased mental status. How you going to do that to a 6th or 7th month old? Beats the fuck out of me. How you going to do that to a 12 to 18 month old? I don't know. Oh, well, okay. They're about to tell us because I'm questioning shit before they tell us the answer. To identify a possible increase in intracranial pressure, it is much more important to recognize a decreased mental status. It is often thought that because the skull is not completely fused together, an infant can tolerate higher intracranial pressures. However, if the swelling is acute, that is, with a rapid onset over hours to days, the dura will not allow the swelling and will result in brain compression. To identify possible dehydration, it is more important to recognize tachycardia and modeling, as well as the caregiver reporting a decrease in tear production and urination. All right, fewer wet diapers. They didn't tell us shit, but I mean, as far as the change in mental status. But I guess the decrease would be, you got to talk to the parent, like, hey, does this how he normally act, does he normally eat his toes? Yes, of course, anyway. Chest and lungs. The differences in chest and lungs for the pediatric patient and the adult patient include, the child's ribs are much more pliable than the adults. They stretch, they bend more, all right? You get old and brittle. This means that the rib cage cannot protect the internal organs as effectively. What the fuck? Wait a minute. Okay, wait. Oh, yeah, I was right. Flexible. All right. While this flexibility decreases the likelihood of rib fractures, it increases the likelihood of internal organ damage with blunt trauma to the chest. Okay. All right. Secondly, the child's ribs are more horizontal than they are rounded. The horizontal nature of the ribs allows very little leverage to increase the anterior and posterior diameter of the chest. This prevents the degree of lift that is necessary for an attempt to increase the volume of air within the chest. Thus, the child must rely much more on the diaphragm to compensate for changes in demands on breathing. All right. Thirdly, lung tissue is much more fragile, which may lead to a higher incidence of pulmonary contusion with blunt trauma to the chest. Fourthly, the chest will move minimally with respiration in the healthy child. Because of the immaturity of the ribs and flexibility of the rib cage, it is normal for the abdomen to rise with inhalation and the abdomen to fall with exhalation. Fifthly, the chest muscles are underdeveloped and used more as accessory muscles in infants and young children. You know that because you see their rib cage moving like a motherfucker when they're breathing, and they're breathing pretty fast, right? This leads to early retractions in respiratory distress. Intercostal muscle retractions, between the ribs that is, will be seen in mild respiratory distress. Suprasternal, above the sternum. Supraclavicular, above the clavicles, and sternal retractions would indicate a more severe respiratory distress. The combination of the compliant chest wall, smaller airways, and diaphragm dependence means that infants' lungs are prone to collapse. Since infections can cause both airway swelling and increased secretions in the airways and lungs, infants typically grunt to try to keep their airways and lung units open. They do this by closing off their vocal cords, laryngeal braking. Not breaking as in B-R-E-A, but B-R-A-K. Laryngeal braking, and bearing down abdominally at the end of inspiration to try to restore or maintain a positive pressure in their lungs to prevent collapse. Try it and see how long you can do it yourself. It's exhausting. Let's do what they just said. Do this by closing off the vocal cords. Close those off. Bearing down abdominally at the end of inspiration to try to restore. Okay. Oh, yeah, that's kind of hard. Yeah, it don't even make sense, actually. You're working real hard to do that shit. You can't even breathe. It's hard. Anyway, respiratory system. The breathing is inadequate once the respiratory rate reaches 60 breaths per minute or greater in children. If the respiratory rate, let me go back. Yeah, like they just said, try it and see how long. I do that with all of this shit. I would try that with, all the respiratory stuff that they tell you to do. Or does your diaphragm move up or down when you breathe in? Even though you can't see it, just think about the shit. Think about what could be happening. Do your ribs move out or in or whatever the fuck? Do your lungs move up or down? Breathe, do the shit and see what happens. And that'll help you answer that damn test question, So try it out. Hey, respiratory system. The breathing is inadequate once the respiratory rate reaches 60 breaths per minute or greater in children. If the respiratory rate begins to decrease, it may be an indication of respiratory failure. Infants may have episodes of apnea in response to stress. Parents may report that their infant stopped breathing for a short period of time and turned blue. This is a very concerning sign and should prompt a rapid transport Secondly, under respiratory systems, differences in between pediatrics and adults. Secondly, infants and children less than 5 years of age will breathe at a rate 2 to 3 times faster than the adult patient. The breaths are also shallower than in an adult, since less volume and pressure are required to ventilate the lungs, right? Makes sense. The muscles of the diaphragm in the infant are prone to fatigue, since this is the primary muscle of respiration. Working to breathe is very costly. The oxygen consumed by the infant who is working to breathe may not be there to supply other organ function. Typically, this infant is too lethargic or tired to respond appropriately. This lack of attitude or normal behavior signifies a very ill infant who needs advanced care immediately. All right? The differences between the cardiovascular systems. The heart rate increases in response to fear, fever, anxiety, hypoxia, activity, and hypovolemia. Sound close to the same shit. Except for fever, maybe. But in infants and secondly, in infants and children, bradycardia is a late response to hypoxia. I'm going to say that again. In infants and children, bradycardia, or slowing of the heart rate, is a late response to hypoxia. In newborns, bradycardia is the initial response to hypoxia. All right? Infants and children have thirdly, infants and children have a smaller circulating blood volume than adults because of their smaller size. Right. I mean, it only makes sense. This means you must stop any bleeding as quickly as possible, since that would be a comparatively small blood loss in an adult would be a major hemorrhage for a child. All right. I skipped what in that sentence? Put it together yourself. I don't give a fuck. All right. Fourthly, hypotension will not usually develop in infants and children until greater than 30% of the blood volume has been lost. The onset of hypotension is sudden once the compensation falls. Fifthly, infants and young children have a limited ability to increase the strength of cardiac contraction. When adults experience cardiovascular compromise, they compensate by increasing the heart rate and the strength of the cardiac contraction and through vasoconstriction. The infant or child does not have the ability to compensate by increasing the strength of cardiac contraction. The pediatric patient's cardiac compensation primarily consists of changes in the heart rate and an increase in the degree of peripheral vasoconstriction, increasing systemic vascular resistance, as evidenced by modeling of the skin and cool extremities. As with the adult patient, the pediatric patient's blood pressure is based on cardiac output and systemic vascular resistance. Remember that equation they just gave you. Anyway, blood pressure equals cardiac output, or CO, times SVR, which is systemic vascular resistance. Blood pressure equals CO times SVR. All right, on to the pediatric and adult differences in the abdomen. The child, number one lead, the child's abdominal musculature is less well developed than the adult's, increasing the likelihood of internal organ damage with blunt trauma to the abdomen. All right. Secondly, until the child reaches puberty, the liver and spleen are more exposed and less protected by the ribs in the abdominal cavity. This offers less protection to the organs against injury. All right, let's talk about the differences in extremities here. The extremities. First of all, the bones of the extremities in a child fracture more often by bending and splintering, referred to as a green stick fracture. All right, the bones of the extremities in a child fracture more often by bending and splintering. And the bending and splintering of these extremities that causes the fracture is referred to as a green stick fracture. All right? Green, I guess, because they're younger, newer. You know, you're green. They're new to it. Their extremities are new to it. So, yeah. The infant and young child's motor development occurs from the head to the toes. Did y'all hear that? The infant and young child's motor development occurs from the head to the toes. That makes sense, right? Of course, because babies give you more, motion or activity in the face than they do, anywhere else at first. If you just think about that shit. The infant and child's motor development occurs from the head to the toes. The head is one of the first things the infant can control. The lack of coordination leads to frequent injury from falls. Yep, because they do fall off beds. They'll throw their head and fall right off the fucking bed. All right. Pediatric and adult differences in the metabolic rate. Infants and children have a much faster metabolic rate even at rest. The cells in their bodies use oxygen and glucose from the bloodstream 2 to 3 times faster than in adults, and periods of apnea, which is absence of breathing, hypoventilation, depressed breathing, or poor oxygenation can be more dangerous. That makes perfect sense, right? That's why they tell you, when you're young, all that running around and shit, you burn them calories real quick. When you get older, people put on weight, of course, because your metabolism slow down like a motherfucker. Central nervous system damage can occur more quickly with more serious injuries affecting respiratory function, resulting in poor ventilation and or oxygenation. This explains why the pediatric patient exhibits signs and symptoms of carbon monoxide poisoning earlier than the adult patient. Why do they exhibit signs and symptoms of carbon monoxide poisoning earlier than the adult patient? Come on, because they just told us, and I just broke it down for you. I just gave you some true-to-life shit. Huh? It's because their metabolism is faster, damn it. So it's going to circulate through their body faster. All right. And thirdly, I think this is the third or second. This is the second difference in metabolic rate for the adult and pediatric patient. Pediatric patients are at a significant risk for the development of acute hypoglycemia because of any of these reasons. 1, poor glucose stores. Okay, yeah. Less sugar than an adult. Okay. 2, inability to stimulate the release of glucose stores from an immature liver. 3, an increased metabolic rate resulting in the utilization of large quantities of glucose. All right. Or 4, a known history of diabetes. Indications of hypoglycemia in the pediatric patient may include twitching, seizures, limpness, eye rolling, apnea, or irregular respirations. What did I just say? Indications of hypoglycemia in the pediatric patient may include twitching, seizures, limpness, eye rolling, apnea, no breathing, or irregular respirations. The onset of the signs and symptoms of hypoglycemia is rapid and, as a result, requires rapid intervention to prevent cerebral injury. All right. Lastly, last but not least, let's talk about the differences between the pediatric patient and adult patient and when it relates to the skin and body surface area, or skin and SBA, or SBA period. All right, first of all, a child's skin surface is large compared to his body mass. All right. A child's skin surface is large compared to his body mass, making children more susceptible to hypothermia in cold environments. You should take great care in protecting the young patient from the extremes in the environment. All right. The skin is thinner. Secondly, I always do that. The skin is thinner and much more delicate than in an adult. There is much less subcutaneous tissue. You got that? That's key. In a child or pediatric patient, the skin is much thinner and much more delicate than in an adult. That baby skin, you already know, is soft. There is much less subcutaneous tissue. Less subcutaneous tissue, along with a poorly developed hypothalamus, leads to temperature regulation problems and hypothermia in newborns. The hypothalamus regulates the temperature control of the body. You got it? All right. Regulation problems with hypothermia in newborns. The lack of subcutaneous tissue also leads to a higher incidence of hypothermia in infants and young children. We're going to stop right there, and we're going to move on with this pediatrics in a bit of a second. Take a nap. Go to the store real quick, get you some juice and cookies or some shit, and we'll get you on the next one. Later.